I request Dr. Jyoti Verekar to introduce our second speaker, Dr. Mukesh Shetye, a senior consultant nephrologist, who will be speaking on role of calcium channel blocker beyond blood pressure control. Dr. Jyoti.
Thank you, Doctor. Dr. Mukesh Shetye completed his MBBS and MD from LTMM College, Mumbai, where he obtained rank in university also. He did his DNB in general medicine from Delhi Board and DNB in nephrology from Hinduja Hospital. Dr. Mukesh Shetye is the founder of Navnath Healthcare, a dialysis network company, and in charge of the patient education program. He is a founder member of Apex Kidney Care Private Limited, a chain of dialysis center across India. Again, he is the founder member of Kimaya Kidney Care, a comprehensive kidney care company. He is the founder member, trustee of eMagic Foundation. He has previously worked as a lecturer in general medicine and nephrology in LTMG Hospital, as a PG lecturer in general medicine. He has held the post of scientific editor of Indian Practitioner and Indian Journal from 1999 to 2011. Dr. Shetye was a team member in Maharashtra State's cadaver kidney transplant, a team member in Thane District's first cadaver kidney transplant, and a team member of Astra, who conducted India's first domino kidney transplant. Dr. Shetye has performed more than 250 kidney transplants. He is also the founder member of first nephrology, urology, super specialty hospital called Nephrol. So here I present Dr. Mukesh Shetye. Mukesh Shetye. I'm so sorry.
Thank you, madam, for that kind introduction. I'll be just in a while. So in just next 15 to 20 minutes, I'll be going through this concept of calcium channel blockers and what is their utility beyond the blood pressure control. So we know that there is a gap in the management of hypertension with calcium channel blocker, and we try to classify now calcium channel as per the voltage gated channels and then their antagonists, because each voltage gated channel which is blocked has a separate effect to exert. And we'll be focusing mainly on a drug called Efonidipin, and I'm sure people have started using Efonidipin. What is its pharmacology? How does it offer control over cardioprotection, renal protection, vascular protection over the other calcium channel blockers? So that's going to be the overview of our talk. So when you talk about the current calcium channel blockers, we see that they are not able to give a proper cardiac protection. For example, Nefrologist causes reflex tachycardia. There is hypertrophy and cardiac remodeling, inadequate correction of myocardial ischemia. There are risk of arrhythmias. So not all calcium channel blockers actually are cardioprotective. Then we didn't see the initial calcium channel blockers being renoprotective. Like for example, Amlodipine. It does come as a drug with good BP control, but unfortunately, it doesn't have anything to offer as renal protection. In fact, there was progressive glomerular hypertension with Amlodipine, inadequate proteinuria reduction, hypertrophy and fibrosis of the renal vasculature continued. It didn't have any beneficial effect on renin and aldosterone. Then when you talk about vascular protection, those initial calcium channel blockers like Nifedipine or Amlodipine, Nitrendipine, so many of them came but didn't actually offer vascular protection as well. And most of these had distressing side effects, like many of them have peripheral edema. We have to discontinue amlodipine, nifedipine whenever our patient suffers from peripheral edema. They had issues like constipation, flushing, and tachycardia. So we were in search of a molecule which probably could overcome these limitations and can offer a better BP control as well as an additional organ protection, and that was our need. So when we classify calcium channels, mainly they are L type, because L channels are mainly seen on the ventricular myocytes, on the peripheral vessels, even on the afferent arterioles. They are also sparsely there on neurons. Then we had P type, which was mainly to do with CNS. Even the R type was mainly to do with CNS. The N type drew our attention because they were neural, and as we know, the afferent arteriole and efferent arteriole have the N-type calcium channel as well. And lately, we had focused on this P-type calcium channel because we realized that they are abundant mainly in the heart and kidney. And these are the two major organs who actually are needed to be protected when there is a background history of hypertension. And P-type channels were found on afferent arteriole, efferent arteriole, also on vasa recta, even in the adrenal cortex. They were also found in the myocytes, SA node, AV node. And that's why anything which probably modulates P calcium channel was our need. So the L-type blockers like the nicardipine, nifedipine, amlodipine, even azilnidipine is considered as LNT, but it has more L blocking action than T blocking action. And all these drugs were excellent BP controlling drugs, but probably, as we mentioned, they didn't offer anything beyond that. Then LNT blocker like the beridipine was used quite for some time, and then now we have efonidipine. And again, there is some more focus given on efonidipine because it has some more advantages over beridipine. The LN blocker, which came in between, has again a predominant L action. The N, the neural innervation of afferent and efferent arteriole, is weakly contributed by cilnidipine. So cilnidipine does come as a good BP controlling drug, but didn't offer much as renoprotective, cardioprotective agent. So that's why there's always a constant comparison between LN blocker and LNT blocker. And efonidipine being LNT blocker is supposed to give some additional advantages over LN blocker. And when only L blocker were used, probably they had great limitation because they didn't offer anything beyond BP control. So these gaps are likely to be filled up with efonidipine, and efonidipine is a newer generation dihydropyridine calcium channel blocker, which was first introduced in 1995. It has a phosphonate moiety at the C5, and that confers unique pharmacological properties. And this is the drug which probably is supposed to offer additional benefits because of its T-type channel blockers. And because of these T-type channel blockers, it offers cardioprotection, it offers renoprotection, it offers vascular protection, and the side effect profile are quite minimum. So what was the utility at cardioprotection and renoprotection and the vascular protection that we are going to elaborate in the coming slides. So when you see the overall benefits of this drug, we see that it is supposed to reduce the sympathetic nervous system activity, and hence it reduces the myocardial ischemia. The SNS activity is exerted by the T channels in the myocardium, SA node and AV node. So obviously when your T channels are blocked in the heart, your SNS activity goes down. And so also the myocardial ischemia governed by the sympathetic nervous tone, and even the same sympathetic surge is responsible for arrhythmogenic action, and even that is minimized. Even the sympathetic surge is the anginal effect. So once you block the extra sympathetic tone in the heart, you automatically create an anti-anginal effect. So that was all the benefit which was offered by efonidipine at the heart. It has some antiplatelet action. At the kidney, they could found that there were tremendous benefits observed at the renal level. And that is unique because that's the only drug which causes equal dilatation of afferent arteriole and efferent arteriole. So afferent arteriole has L channel, that is not only blocked, but the efferent channel has T channel. And because T channels are also blocked, you have equal dilatation of afferent and efferent arteriole. And the advantage of that is the intraglomerular pressure drops, the renal fibrosis minimizes, plus the additional benefit of efonidipine is it is an anti-aldosterone, an anti-renin drug as well. And that will, next slides would throw some more light how it becomes an anti-aldosterone, anti-renin drug. Plus there is arterial stiffness which is minimized, the vascular toxicity is minimized, there is antioxidant effect on the vessels, and that is how it becomes a vascular protective. It is cerebroprotective. It has some effect as insulin resistance is minimized, and the latest adverse drug reactions are also least observed with efonidipine. So these are all the major advantages which we see with Efonidipin. And now we come back to the first aspect of it, that how it becomes a cardioprotective drug. We just saw that the channels like the sympathetic channels are there in the heart, mainly at the nodes like SA node or AV node, and also into the myocyte, and that is basically activated by sympathetic tone. So once the T channels are blocked, your sympathetic tone decreases, that reduces the SNS activity, enhances the parasympathetic nervous activity. The tachycardia is in fact minimized. They in fact come down in their heart rate. Because heart rate is reduced, the myocardial oxygen consumption is gone down, and that is how it contributes the anti-anginal effect as well. So that is something which is at the cardioprotective effect. So Efonidipin reduces myocardial oxygen demand, improves coronary blood supply, because even coronaries have T channels, and because the T channels are blocked, it automatically acts as a coronary vasodilator. So it's just like mimicking like an isosorboid dinitrate effect, that it becomes a coronary vasodilator. Efonidipin has a coronary vasodilator effect. It is an anti-arrhythmic drug. It blocks the SA nodal emission as well as AV nodal emission, so that net heart rate comes down, and that is how all these three together would contribute for cardioprotection. There is some additional benefit of Efonidipin because it blocks the aldosterone level also, which are secreted by T channels of adrenal cortex, and because T channels in the adrenal cortex are blocked by Efonidipin, aldosterone goes down, and there are some additional benefits because of aldosterone blockage, because aldosterone is now coming up as a new toxin for the heart. So once the aldosterone level goes down, naturally there is a beneficial effect at the heart. So these are the advantages we see. We already discussed about anti-arrhythmogenic effect. The antiplatelet action of Efonidipin is supposed to be because Efonidipin therapy reduces the markers of platelet activation, and the platelet activation minimized reduces the risk of vascular injury and atherosclerosis. So these we call it as pleiotropic effect, though they are not the predominant effect for which we use. These are the additional benefits observed. Though minor, it does contribute to the benefit for the overall outcome of the patient. So what is now most important is correlation with the renal protection. We know that the high blood pressure and the kidney damage is a vicious cycle. Whenever there is kidney damage, the kidney itself produces blood pressure called as renal hypertension. And if your renal hypertension is not controlled, it will now keep damaging the kidney. So it becomes a vicious cycle, and in order to break this vicious cycle, you have to stabilize the blood pressure. At the same time, if I can offer some more additional renoprotective effect, then that drug is naturally preferred. So that is what we are trying to discuss, that if blood pressure remains high, the systemic blood pressure is transferred to intraglomerular hypertension. So the renovascular resistance goes up, and over a period of time, suppose someone is essential hypertensive at the age of 20 or 30, over a period of next 20 to 25 years, the increased renovascular resistance, then leading to glomerular ischemic changes, then leading to microalbuminuria, then leading to more and more progressive proteinuria, and then leading to increased arterial resistance, progressive nephrosclerosis or glomerulosclerosis will push this kidney into end-stage kidney disease. And that is why we say the two most common cause of ESRD is blood pressure and diabetes, because both these actually follow this algorithm, that from the systemic circulation, the effect comes on intraglomerular apparatus, the vascular resistance goes up, and that promotes the microalbuminuria, then more proteinuria, and then fibrosis. And that is why this particular progression can be prevented if you have a drug which not only controls systemic hypertension, so automatically your intraglomerular pressure comes down, but additional benefit could have been if it is anti-proteinuric, because the overall damage of the organ is because of ongoing proteinuria. And that is why the role of Efonidipin comes, because it is not only anti-hypertensive, it is also anti-proteinuric. And that will throw some light on this concept, that if you have a history of diabetes and blood pressure, naturally the intraglomerular damage translates to endothelial damage. That's the innermost layer of this GBM, the glomerular basement membrane, the capillary endothelium, then the capillary basement membrane, and the epithelium of the tubule. That's a triad. But the high pressure is first exerted on the endothelial lining. And unless the endothelium is damaged, you cannot have leakage of protein. So my basic concept is that if you have microalbuminuria, and often general practitioner would see a urine report where you will see urine protein is 1+. And if I subject this patient for microalbuminuria, the microalbuminuria often comes more than 300, or more than 30 to 300 is the range. If it is more than 300, we know that, oh, there is already microalbuminuria. This would mean that this endothelium is already fired. So microalbuminuria is considered as a surrogate marker of endothelial dysfunction. and that is the key factor by which diabetes and hypertension is going to progress. Then this microalbuminuria progresses to macroproteinuria, nephrotic range proteinuria, and end-stage renal disease. So if I have to stabilize this kidney, then I have to revert this microalbuminuria, because if I'm able to revert this microalbuminuria, it would mean the endothelium is repaired, and that will only happen in the early stage. Once endothelium is disrupted and more proteinuria continues, then probably this disease is already out of control and they will progress to end-stage renal disease. So in the very early stage, where those cases are actually seen by general practitioners, there is a wide entity needed to look for microalbuminuria. Imagine this entity as correlation with endothelial dysfunction. Treat microalbuminuria aggressively, then only you want to safeguard the endothelium. And you are not only going to safeguard endothelium at the glomerular level, but also at the coronary level or also at the cerebral level. So actually you will be overall reducing the incidence of ischemic stroke as well as the cerebral stroke. So that is why it is important to be very active in controlling microalbuminuria. So there are the two parameters by which the chronic kidney disease progresses. One, the underlying disease, if that is very aggressive like diabetic nephropathy, naturally they will be more aggressively progressing. But next would be elevated blood pressure and proteinuria. So if I'm able to control at least the two factors which are in my hand, control blood pressure and the early microalbuminuria, maybe I'll be able to increase the life of kidney disease and prevent the further progression to next stages of chronic kidney disease. So this is just the concept that you are able to see a glomerulus and afferent and efferent arteriole. Okay, basically the tone is usually controlled by the afferent and efferent vasodilators and constrictors. And there's a nice balance called as renal autoregulation. And if that is maintained, usually your intraglomerular pressure is maintained. There is no endothelial disruption. As you can see that this vessel has this endothelial lining. Unless this is disrupted, protein cannot leak out into the tubular space. So this is a usual normal renal autoregulation. But when I am giving drugs which are only afferent arterial dilators, which can be drugs like Efonidipin or Nefrologist or hydralazine, then you are only going to treat systemic blood pressure because there is a vasodilator effect, but actually you are going to increase the intraglomerular pressure. Efferent arterial has remained the same. Naturally, afferent would dilate, efferent remains the same, intraglomerular pressure goes up, and that in fact goes into more and more protein loss. And now if I even check efferent arterial dilatation, afferent remains the same. Still, I'm going to create some benefit because blood comes and quickly goes to the efferent arterial vessel because the tone is less, intraglomerular pressure is low, and there is no proteinuria. That's why ACE inhibitors and ARBs came as a very important neuroprotective drug, because ACE inhibitors and ARBs could prevent the efferent arterial constriction. They dilated efferent arteriole, intraglomerular pressure dropped down, and that is how they became nephroprotective. But imagine you have a drug which dilates both equally. Afferent arteriole is also dilated, efferent is also dilated. Then naturally that will create more magic, because afferent arterial dilatation will ensure that the systemic blood pressure is controlled. Efferent arterial dilatation will ensure that the intraglomerular pressure is not likely to be high. Proteinuria would stop, BP will be controlled, and there will be more and more renal protection. That's why we were in need of a drug which will result to both afferent and efferent dilatation equally. And this is now possible because you have on the afferent arteriole the L type as well as T type, but see the efferent arteriole, only T type are represented. So when I'm using cilnidipine, amlodipine, nifedipine, I'm only dilating afferent arteriole, but efferent arteriole is more or less the same. And though there is a neuronal innervation called N type, when cilnidipine acts on N type of efferent arteriole, there's an indirect effect. This is weaker as compared to T channel blocker. So when I'm using Efonidipin, there's a direct efferent arterial dilatation, direct afferent arterial dilatation, less intraglomerular pressure, BP is well controlled, and so also the intraglomerular pressure being controlled, your proteinuria is controlled. So that is the utility of Efonidipin over the other calcium channel blocker. So if I had to summarize the effect, the hemodynamic effect of Efonidipin are that there is into equal dilatation of both, the renal blood flow improves, but the vascular resistance drops, filtration fraction drops, proteinuria minimizes, plus there is an independent action on the T channels of aldosterone secreting adrenal cortex, and the aldosterone level also drops. Plus there are some hemodynamic effects seen, that is they act on the RHO kinase activity, and that basically prevents the angiotensin II ill effects on the kidney tissue, and the fibrotic changes induced by nuclear factor Kb, and that is how your renal tubular interstitial damage is also prevented. That's more at the pleiotropic effect, but the hemodynamic effect carries more significance, and both combined offers more renal protection. So that is how the different action of calcium channel blockers on renal microcirculation. If I to summarize, then efonidipin causes marked dilatation of both afferent efferent, prevents glomerular hypertension, and reduces proteinuria as compared to only L type or even LN type. So the way to go is to use LNT rather than L type alone or LN blocker alone, and that is how your efonidipin might be a good player in this background. Now, efonidipin, as it is the same thing we summarize in this layer, and it has been compared with the other two common drugs which we use, that is benetipin and ezellnetipin. Benetipin dilates afferent glomerular arteries more than efferent. Again, so partial protection. Ezellnetipin dilates afferent more than efferent. So again, partial protection. The equal dilatation of both afferent and efferent is mainly seen with efonidipin. So there was a head-to-head comparison between the benetipin and ezellnetipin group, and they found out that they are yet, though labeled as double blockers, they are mainly L blocker rather than the T blocker, and that is why the best T blocker along with L blocker being efonidipin, that carries more significance. So the filtration fraction drops. The utility of filtration fraction dropping is your proteinuria will drop, because that is the pressure at the intraglomerular apparatus, which is best reduced again by efonidipin as compared to nifedipine, cilnidipine, or ezellnetipin, and that is why again when the filtration fraction is equated, this is again supposed to be the best. I was mentioning on this aldosterone. Now aldosterone is the more active player or renin-angiotensin aldosterone axis. We know now aldosterone is a toxin. It has its independent effect. It causes norepinephrine release. It causes endothelial dysfunction. It causes decreased vascular compliance. It is an independent risk factor for stroke, renal failure, coronary artery disease, myocardial infarction. It interferes with COX-2 and again causes more osteopontin generation. All these toxins are now labeled as aldosterone governed effect on the vasculature, on the heart, on the kidney, and that is why blocking aldosterone has become the end thing for organ protection. Cardiologists have already been using aldosterone antagonists for control of the myocardial dysfunction, and even now nephrologists have also started using aldosterone antagonists, because that also has to offer renal protection, and they are now the drug of choice for malignant hypertension. So that is why aldosterone blockage is necessary. And this is the chart where aldosterone blockers have been independently utilized for a variety of situations like resistant hypertension, chronic heart failure, LV dysfunction. Of course, you have to assess the potassium and creatinine. If there is no hyperkalemia, one can safely use. If there is hyperkalemia, naturally it is not drug of choice. Even in obesity and obstructive sleep apnea, one of the mechanisms which has been responsible for genesis of hypertension is hyperaldosteronism. And that is why in both obese individual and obstructive sleep apnea, people have started using aldosterone blockers, because that is supposed to offer additional benefit. And there are now umpteen papers coming up for mineralocorticoid receptor antagonists, where spironolactone or eplerenone have been found to be effective even in reducing proteinuria, because aldosterone is a player at the glomeruli and that promotes proteinuria. And these are the studies which actually have equated their effect as ACE inhibitor and ARB, and the quantity of proteinuria reduction was almost similar. That means the status of aldosterone antagonism is now almost equating to ACE inhibitor and ARB, and that's why aldosterone antagonists have been in the limelight. This is a study which was conducted, and based on this meta-analysis, they say that aldosterone antagonist is safe and effective therapy in resistant hypertension. That means you already use first-line drug, then you're using second-line drug, beta blockers, calcium channel blockers, central blockers, potent vasodilator. When all these drugs are not effective and you label the patient as resistant hypertension, what is working in there for controlling BP is aldosterone antagonist. So 150 mg of spironolactone would do more wonder in controlling their BP, because resistant hypertension, one of the mechanisms is hyperaldosteronism. That causes resistance to hypertension, and that is how that hypertension is never controlled by the other common drugs. So now even using aldosterone blockers is the important way to go to offer organ protection. And now how efonidipin does that is, the T-type calcium channels are responsible for aldosterone secretion in the adrenal cortex, and this is again blocked by efonidipin. By blocking the T channels which are aldosterone secreting, the aldosterone level drastically comes down. And this is one extra advantage over ezellnetipin or nifedipin or amlodipine or any other calcium channel blocker, because none of the other calcium channel blockers help in reducing aldosterone level, while efinidipine effectively reduces the aldosterone level. So that is the main utility. Same effect has been seen for renin and prorenin secretion also, because renin and prorenin would promote vasoconstriction, and they are in fact responsible factor for renal tubulointerstitial damage, fibrosis. And there are again T channels which are at the juxtaglomerular apparatus. Stimulating T channels will act to stimulate and release renin and prorenin, but blocking T channels by efinidipine would effectively block the secretion of renin and prorenin, and that is how your renin level goes down, prorenin level goes down. So almost of this RAS axis, renin, angiotensin, aldosterone axis, three of the players, the precursor prorenin into renin, and finally the aldosterone, have been blocked by efinidipine. So though it's not a RAS blocker per se, that status we always give it to ARB or ACE inhibitor, but these actions are almost rhyming without the risk of increasing creatinine, without the risk of any further renal damage, without the risk of hyperkalemia, and that is why it is actually a safer drug even as compared to ACE blockers or ARBs whenever you're thinking about renal protection. So that is the utility of efinidipine. The last component being vascular protective action, that when the cardio-ankle vascular index was calculated, which is based on a formula where you use systolic pressure, the blood density, and the blood flow velocity, all that has been put into a formula. And when you check cardio-ankle vascular index, this is effectively reduced only with efinidipine and not with any other calcium channel blocker. And probably there is some endothelial protective effect offered by the drug, because there are various receptors which are there in the vasculature, which are again vasculotoxic, like thrombomodulin, platelet aggregating factor, and they have been inhibited because their secretion is by T channels, and they can be blocked by the vascular effect on T channels by efinidipine, and that's why it has been considered as vasculoprotective. It is anti-atherogenic action because of the cellular ingredients being blocked. It reduces insulin resistance and also offers cellular protection. So these are some of the other benefits which we see with efinidipine, which we do not see with other drugs. So this is a same effect, that the efinidipine equally dilates arterioles and venules. While when you talk about calcium channel blockers, they do dilate arteriole, but they do not dilate vein, because the veins have T channels and the arterioles have L channels. So when you give cilnidipine or nifedipine or amlodipine, because only arterioles have dilated and the veins have not, there is an increased pressure governed towards the vein, and that is why edema comes. So peripheral edema is the most common side effect of calcium channel blocker, not seen with efinidipine because it also dilutes venules, because T channels are only on the venule and there are L channels on the afferent arteriole. So arterioles dilate, venules dilate, there is no stagnated pressure, and that's why edema does not come out. So it is the same concept that when you use LNT blocker, the edema doesn't come, but when you are using only L blocker, you are likely to promote edema, and that is most commonly seen with nifedipine, amlodipine. Less seen with cilnidipine because some of the neuronal pathway controlling venules are also blocked. The N channel is blocked by cilnidipine, the edema is less, but of course it is not zero. Why? Because T channels are the important channels of the veins and they have been blocked, you see a significant reduction in edema or almost no edema with efinidipine. So that's the advantage. Now, with all these headings were compared between amlodipine and venidipine and variety of other drugs that reflex tachycardia, there is a benefit for efinidipine because efinidipine doesn't lead to reflex tachycardia. It's anti-anginal, it is anti-platelet, the arterial stiffness reduces, there is renal protection offered, the plasma aldosterone level goes down, and the edema does not come. All these benefits are again not seen with other calcium channel blocker. When there was a head-to-head comparison between efinidipine and azanlidipine, it was same that azanlidipine is mainly restricted for control of essential hypertension, but efinidipine has been approved for control of essential hypertension, renal parenchymal hypertension, and angina. So its anti-anginal effect is also being notified by the drug controller, and it has been certified that this drug can be used as anti-anginal as well. So its effect on the coronary vasculature has been approved by the drug controller. So that's the advantage. It's a real dual calcium channel blocker, and that is why it has more benefit to offer as compared to azanlidipine. And again, when you compare all other properties like renovascular dilator action, anti-proteinuric action, cardio-ankle vascular index reduction, overall benefits, mortality, all those when compared with azanlidipine, efinidipine could pass those variety of segments. So efinidipine has a short half-life and it's an anti-epileptic effect much longer. It's a unique characteristic because it is lipophilic. It has a strong membrane binding and slow dissociation. So it's actually truly a long hour controlling drug. though its antihypertensive effects last longer, despite of the fact that the half-life is short. That means the metabolites continue to act as antihypertensive, and it is usually given once a day in mild hypertension, but can be given twice a day to maintain two peak levels. So 20 mg daily or 40 mg daily, or could be 40 mg twice a day. Even 40 mg once daily has been approved for chronic stable angina, and this was that certificate which says that yes, it can be used for all three indications. So Efonidipin used in special population, that is geriatric use. It is usually given at a low dose, but of course it is not recommended in pregnancy, lactation, like any other calcium channel blocker. Its pediatric use below 18 years is not recommended. It has no major need for adjusting the drug in renal impairment and hepatic impairment. So it can be used in both these situations. And so unique dual calcium channel blocker with potent antihypertensive action, has a pleiotropic effect, excellent BP control, enhanced cardioprotection, enhanced renal protection, vascular protection. It has a unique antiplatelet activity, improves insulin resistance, and most important, the side effects profile has been very low. Pedal edema, constipation rate, reflex tachycardia, these are not observed with Efonidipin. So basically, it's a drug which has come as a newer LNT blocker, offering variety of actions, has benefits to offer beyond the blood pressure control, and it's a truly organ protective drug. So that was the basic, a very short talk to just upgrade you about these newer antihypertensives. Thank you. So we'll be open to questions if any.
Sir, in chat box, there are a few questions. If you can help out, Dr. Amod Borkar is asking a few questions there in the chat.
Yeah. Okay. Yeah, so one of the question was, does Efonidipin cause reflex tachycardia? In fact, I just mentioned that it wouldn't, because the sympathetic nerves innervation on AC node and AV node are again governed by T channels, and Efonidipin being a T channel blocker, it doesn't lead to any increased enhanced sympathetic activity on AC node and AV node, and that is why you do not see reflex tachycardia in those patients. If a patient is on verapamil, how do we switch to Efonidipin? Can we co-prescribe? Of course, the indications are different. Verapamil we do not use as a very potent antihypertensive. Often it is prescribed for the antiarrhythmic effect, like in supraventricular tachycardia. And you can, in case you're using verapamil for supraventricular tachycardia, then it may not be abruptly withdrawn. You introduce Efonidipin. Efonidipin also has antiarrhythmic effect. And once you're satisfied that Efonidipin is able to maintain the heart rate as well as the blood pressure, slowly you can go down on verapamil and continue on Efonidipin. So of course, the switchover is possible, and switchover is in fact more indicated because it does not lead to all the benefits with verapamil which Efonidipin is supposed to offer. I think I'm able to see only those two questions. If any further.
Dr. Nayak, sir, yeah.
Dr. Rajesh Naik can say something. Dr. Rajesh Naik, kindly unmute.
Very excellent presentation, Dr. Amar. Only one question I would like to just ask, or rather a comment. In a resistant hypertension, we normally, when all the drugs are not working, we do use now aldosterone antagonist. Can we use combined spironolactone with Efonidipin? That's my question.
Yeah, definitely we can combine. In fact, there are such combinations.
What will be the problem? What will be the problem, especially CKD? In CKD, we know that we have to use 3 or 4 triprodrugs. We use amlodipine or Efonidipin now, along with miniprep or alpha blockers. We use clonidine, or we want to use a central blocker. Even in such conditions, sometimes it is, you must have seen that in CKDs, this blood pressure is a very difficult thing to correct, especially after a post-transplant also. In such people, if you add a spironolactone along with Efonidipin, do you find that the other drugs can be tapered off?
Yeah, in fact, this is the observation in our cases, that if these two drugs are used, you probably may not require other vasodilator drugs. Especially, you will not require even centrally blocking drugs like chloride. And
what is the chance of hyperkalemia?
So of course, Efonidipin has no interference with potassium. It's only the aldactone which probably or spironolactone will have hyperkalemia. You have to be watchful. So we recommend this in CKD stage 1, 2, and 3, where per se potassium excretion is not all that affected. But you have to be very, very careful when you're using it in stage 4, and especially they are not on any renal replacement therapy, because there the chances of hyperkalemia would be very high. So we simultaneously educate them about potassium control by diet, and if possible, we add other diuretic, which is potassium losing. So not torsemide, but just plain simple furosemide, which is a very good potassium losing drug. And sometimes this combination guards the balance between potassium as well as the effect of spironolactone.
Thank you. That's it.
Thank you, Dr. Mukesh Shetty, for your excellent talk. Hope all our members have really gained a lot of knowledge from both of the speakers today. I request our treasurer, Dr. Yogesh Shetty, for Thanksgiving. Is he there? Yeah. Dr. Yogesh Shetty. Dr. Yogesh Shetty, kindly give Thanksgiving. I think he's busy. Okay.
Hello, am I audible?
Yes, you're audible, sir.
Yes, you are audible. Come. I think he's busy somewhere, and I would like to thank both of the speakers. He's come. Yogesh, are you there? Yogesh, are you there? Can you say something? Okay, I thank both the speakers, Dr. Anil Tambe and Dr. Mukesh Shetty, to take some time and give us such a wonderful talk today on General Practitioner Association. I even thank Dr. Jyoti Verekar and Dr. Rajesh Naik to be a moderator. I thank Juventus for arranging the CME. Especially thanks to Mr. Shailendra Phatak and Mr. Uday Shaha, and even our executive manager, Mr. Vaibhav, to put his all efforts. And thank you very much. Members, thank you very much for attending in large numbers. Thank you. Thank you, all of you.
Thank you.
Yeah, thank you everyone for excellent participation. Thanks a lot. So on behalf of Zoventus Lifestyle, I would like to convey my sincere thanks to the Goa General Practice Association entire faculty team, the president, treasurer, secretary, Dr. Samuel, especially for giving this opportunity to Juventus for conducting their webinar session. Thank you very much to our speakers, Professor Dr. Anil Tambe, sir, guiding through the entire session on COVID and how to best manage during the general practice with minimum resources, including vaccination. Thank you very much, Dr. Mukesh Shetty, sir, for excellent presentation and guiding through about role of calcium channel blocker beyond blood pressure control. And thank you, Dr. Rajesh Naik, sir, for entire coordination very well for the full session. So thank you all participants for sparing this time. On on behalf of Zoventus, I would just like to convey our brands are freely available wherever they are required. Efonidipin is available as a brand, Efnocar 20 and 40 milligram, freely across the country. And wherever require antioxidant therapy, zinc, omega-3 fatty acid, we have tailor-made Bevon CD available. So whichever deserving patients are there, do pass on the benefit. Thank you very much. Thank you all. And see you. Yeah.
Thank you.
Thank you. Thank you. Thank you all participants. Yes, you can log out. Thank you very much. Thank you. Thank you for excellent participation. Thank you all participants. Thank you very much. Thank you very much.
Thank you.
Thanks. Thanks. Yeah. Yeah. Bye, sir. Yeah. Yes, I request all participants, you can log out. Yes, thank you very much.